Can I begin? Great. Yeah, so again, I want to say thank you to everybody. It's wonderful to be here simultaneously in Copenhagen and Silicon Valley and Toronto, and I look forward to the discussion and to share some of my thoughts on this topic area with you. I should also say that rarely when I give talks are my children with me. My children are also sharing bandwidth as they're doing virtual school this week, so hopefully everything will be smooth for the rest of the next half hour or so. So I would like to talk to you about some of the risks of deep machine learning at a fairly high level. And then I want to get into a bit more depth about how we might be able to mitigate some of these risks using a new emerging series of techniques called explainable AI, or XAI for short. From there, I'm going to discuss a little bit of my own experience with sort of applying deep machine learning in healthcare. Partially from a research perspective, but mostly from the perspective of one of the companies that Christian just mentioned. And then I'll wrap it up with a bit more discussion about some additional implications for practice that will hopefully wrap up some of the threads discussed in parts 1 and 2. So first, I would like to travel back to the distant past of, say, 2014 or 2015, when artificial intelligence was still something sort of done in private. It didn't achieve the scope it has today. But already there were challenges in healthcare that were well known, and they were well known for decades. And increasingly there was more empirical evidence that the way we practice healthcare currently is fraught with problems, it's unsustainable, but unfortunately there wasn't really any solution to many of these problems. So I want to highlight some of them. Most of the challenges I want to highlight have to do with like humans and our own biases, our own cognitive limits. So I mean, humans, the machinery of healthcare up until today, we're just very bad with information. So when patients and doctors communicate, there's a lot of miscommunication that happens. There's a study that shows that about half of American adults, it might be even higher than this, have a great amount of difficulty understanding and acting on the health information that's conveyed to them. So, they're prescribed a bottle of pills and they're asked to take it for 2 weeks, but after feeling better, after just 2 days of taking these pills, they decide, I don't need these pills anymore, which can cause issues. There's also obviously challenges with helping people understand vaccination. But more generally than just a patient-doctor interaction, humans have bad memory, our skills go obsolete, we have various kinds of cognitive biases, there's constrictions on our time. There's recency bias. So if we've seen a certain case or we're exposed to a certain treatment or product, we're more likely to prescribe those or identify those in the present. And there's various other kinds of human biases. So one example of recency bias is that if doctors end up seeing advertisement or media exposure for certain kinds of diseases, they're more likely to overdiagnose those diseases. More to the point, a more recent study showed that almost 41,000 patients die in intensive care just in the United States every year, and just due to misdiagnosis or misunderstanding. So this is, on the order of, multiple airplanes full of passengers going down every single day, just due to this one issue, which is usually not even, like, we're so used to it by now that we don't even almost view it as a problem. To hammer home that point a bit more, most of these ways that humans kind of cause misdiagnosis is due to cognitive factors, just simple mistakes, as opposed to kind of communication breakdown. So cognitive factors are about almost 3/4 of all cases of misdiagnosis. So typically a case is closed too early. And finally, one of my favorite examples to kind of hammer home this point is an older study, but it still holds up today. In 1990, Eddie showed, I think it was about 24 surgeons, or many surgeons, descriptions of surgical problems. And these surgeons were asked a simple question: should the patient in this description have the surgery? And controlling for experimental conditions, about half of these top surgeons said yes, this patient should have a surgery, and half said no. And it's been remarked many times that this is no better than just flipping a coin. So why are we paying these surgeons all this money to make decisions that are no better than flipping a coin, when really a coin, you get a coin for 25 cents. More troubling, is that the same cases were presented to the same surgeons a few months later. And again, almost half of these surgeons gave conflicting answers upon retesting. I mean, this is one study, but it kind of shows that we imagine that healthcare operates in a mechanistic sort of way, but really under the hood, we have a lot of our own challenges with the human mind causing some of these problems we see. So this on the left is Jeff Hinton. He was a professor at the University of Toronto who basically invented deep neural networks from the 90s, but especially into the early 2000s. We owe most of the success of modern machine learning to him. Now, about 4 years ago, he gave a talk in Toronto, and he had this quote, which I just want to read out to you. He said, I think that if you work as a radiologist, you are like Wile E. Coyote, that cartoon animal in the cartoon. You're already over the edge of the cliff, but you haven't yet looked down. So you're kind of floating there, but you're doomed, essentially. And Jeff Hinton said, it's just completely obvious that in 5 years, deep learning is going to do better than radiologists. And then he said it might be 10 years. And I like this quote for various reasons. One, this is a very Jeff thing to say. There's a lot of hype and excitement around machine learning, and it's supposed to solve all of our problems. But even him, the progenitor of modern artificial intelligence, concedes that he's not quite sure if the revolution is going to come in 5 years or 10 years. And another reason I like this quote is that, well, he said this almost 5 years ago, and still there are radiologists who are still doing their work. So we have to take some of the hype, the excitement around machine learning with a bit of a grain of salt. Regardless, when we hear quotes like this, and when we're aware of problems in modern healthcare, there was a flurry of kind of popular press about the challenges of AI and what to expect. And we have all these kind of doom and gloom kind of news articles. The robots will replace doctors in healthcare. Artificial intelligence is telling doctors how to do their jobs. Robots could soon replace doctors soon. So there's a lot of horrifying imagery about this. And typically we see, when we talk about AI in the popular press, there's the image of the Terminator, and we're meant to be very scared about the future of AI. Now, I also worry about the future of AI. I've been doing it for a very long time, even before I started my undergrad, I was interested in AI. So I'm very happy to see the progress it's making, but I think there's a good cause for concern as well. But the cause of concern is not going to be in the form of the Terminator, and it's not going to necessarily be in the form of AI completely wiping out entire industries. I think the really frightening future of AI looks like this. So here the picture is of an older woman who's sitting at home and enjoying a nice cup of coffee and a conversation with Siri or Alexa. And this seems pretty innocuous, and most people kind of look at this and think this is fine. This is the direction we're already headed. But there's more and more work in healthcare around the world trying to get people to do care at home. So if we can discharge people from hospitals early and monitor their progress, or even assess them, whether we're having to have them come into the hospital or to see a doctor, just have them talk to Siri and let Siri do the diagnosis herself, will save a lot of money, a lot of time, a lot of headache. So this is the kind of the future of AI that I think a lot of people would like to see come to fruition. And it's backed up a little bit by the economics of healthcare. So here's slightly older kind of snapshots of where healthcare money goes to in Ontario and the United States. So Ontario has a relatively modern healthcare system, a single payer system, and America does not yet. But even despite our differences in how we practice health across the border on this continent, we can see that a lot of the expenditures are the same, in particular hospitals and physicians. So hospitals and physicians, the two of them take up more than half of the total expenditure of healthcare in North America. So if we can reduce the amount we spend on hospitals and reduce the amount we spend on physicians, this would help reduce some of the burden on healthcare. And indeed, the previous Premier of Ontario has this quote that she wants to move the province from a solely hospital-centered system towards something of a more community primary care system. So, let people call in from home. We're seeing a lot of this in the age of COVID. It's being forced on us where doctors have to do virtual care. But this will just accelerate what we're already expecting to have happen. So I want to see an example of, instead of connecting to a doctor over Zoom, maybe we can replace the doctor altogether. So this is an example from USC from about 10 or 11 years ago, where there weren't enough care workers to talk to American veterans of war from the military. So the idea was you can create this thing called SimCoach, which would be like a chatbot that people with post-traumatic stress disorder could speak to and talk about their problems. And there was a good amount of research that suggested that the mere act of talking, even if it's with this fictional virtual avatar, is beneficial. So there's some benefit to this. And I think there's a lot of good we can do with, not necessarily replacing doctors, but when their doctors aren't available, giving a virtual outlet to some of these, the need to connect. In fact, some of our own research in Toronto is with a mental health hospital, and we're looking into chatbots to help people quit smoking, for example. Now, things can go wrong. So this is where the talk turns to the left, and I try to scare you a little bit. So here's some examples from people expressing kind of thoughts of depression, anxiety to Siri, right? To the only AI that most of us have available to us. So if you were to say something like, remind me to kill myself tomorrow to Siri, there's a very simple algorithm. She sees the word remind, and then whatever follows remind, she'll just put that into the reminders app. So remind me to kill myself, boom, you have a reminder to do that tomorrow. If you say you're going to jump off a bridge, there's a little bit of code that says, well, bridges are things that we find on maps. So I'll open up the map app, I'll find bridges that are close to you, and then I'll show you what those bridges are so you can complete your task as efficiently as possible. This made its way into the news, and Apple quickly patched it. So there's some more simple algorithms coded up by engineers in Cupertino, California. If you say something that the code thinks indicates self-harm, like I'm thinking of killing myself, then now there's a kind of a prepackaged sentence. If you're thinking about suicide or self-harm, there's this National Suicide Prevention Lifeline, and here's the number, and I can just call them for you if you'd like. And then she waits for you to answer, and if you say, no, I'm just going to kill myself, there's no follow-up code, she still fails pretty miserably at that point. Now, the caveat is that this is sort of kind of customer-facing AI. It's not really machine learning, and I don't get to really define machine learning today. But I think, as most of you know, the core of machine learning is not these kind of bits of code that are written by humans to mimic human intelligence, but instead machine learning is all about writing small bits of code that instead looks at lots of data and learns the patterns that allow it to mimic humans. So Siri is not really machine learning. It's just coded to act like a human. But machine learning is supposed to be different. It's supposed to be better. So is machine learning also kind of brittle? So here's an example of machine learning applied to healthcare. This is sort of the canonical example. There's a paper from 2017 in Nature where the authors wanted to train a modern neural network to identify whether a skin lesion was benign, like those in the top, or malignant, like those in the bottom. I think most of us can't really tell these apart, but with 130,000 images that were labeled as benign or malignant, a neural network was trained to tell the difference between these two things. Now, an interesting thing I want to mention is that one of the benefits of machine learning is that you don't need to spend a lot of time kind of constructing theoretical frameworks and forcing the code to fall into those frameworks. If you were to just give lots and lots of examples of data to modern neural networks, the neural network itself can find underlying patterns that might have something to do with our interpretation of what the categorization really means, but without us having to actually tell it. So the interesting thing in this paper was that the neural network automatically kind of clustered together melanomas, nevi, basal cell carcinomas, so all these different subtypes of benign and malignant skin lesions. AI, or the machine learning, was able to differentiate these without being told anything about them. And then clinicians are happy. It says that, well, it's good. The neural network is learning something that we know to be an underlying characteristic of the data. So it kind of goes to show that this neural network is really learning something useful, and it's not just overfitting to the data, which we'll talk about in a bit. And finally, I mean, most of what the hype is all about is the ability of neural networks to do better than humans. So what these graphs show is the specificity sensitivity, how good it's doing, the neural network in blue. We want this curve to be as close to the upper right corner as possible. And all of these red dots represent the specificity and sensitivity of humans. And this paper showed that in a bunch of cases. The neural network in blue was more specific and more sensitive to the data than 20 out of the 21 of the best humans that they could find for this task. Now, one thing that came up a few months later is that, well, these data all came from people with light-colored skin, and the same model, the same system, wouldn't be nearly as accurate if it was given darker skin images to classify. So this is the kind of the one crack that we realize, okay, you know, just because something works once doesn't mean it generalizes to all conditions. Around that time, actually, a few years earlier, there was a really good paper called Deep Neural Networks Are Easily Fooled, which describes how things can go wrong, like in this case of, you know, does it work well on light skin versus dark skin? So what this paper showed was that, well, you can have a model that can be extremely accurate in identifying what's in an image. So on the left here are just plain images, and you know, someone can train a neural network to identify this as a school bus, and this is a cheetah, I think. This is, I think, Angkor Wat. Again, with these high accuracies, 95, 96% accuracy, these very impressive sounding things. Now, what this paper showed was that you could train a second neural network to learn itself how to create some noise to confuse the first neural network. So the second neural network would produce this image in the middle, and then add just, you know, a fraction of a percent of this image to the first image. So for you and I, looking at this image on the right, we can't tell any difference really from the image on the left. It looks exactly the same, and we say this is definitely a school bus. But it's changed ever so slightly, and specifically in order to you know, cheat the first neural network, that now we can get the neural network, the first one that was so accurate, to detect anything we wanted. So we can now just say this school bus, this cheetah, and this building are all an ostrich, or this dog and this insect and this bit of, I think, home electronics. These are all ostriches also. And you can see how this could be a problem, right? If you can just change the data a little bit, these neural networks are entirely brittle. They fall apart, and they can really detect whatever we want them to detect, which has lots of implications for security. So I'm going to brush over briefly some of these aspects. I think there's a risk that AI in the wrong hands can be very dangerous. You know, if only a few small countries or a few companies control AI, then that won't be good for the vast majority of people necessarily. But I think a bigger risk is that people who are trying to build AI from the perspective of doing good might give goals that are too abstract. And then therefore, if they don't take care, these neural networks can find a trick to achieve impressive accuracies. But what's going on under the hood, we don't understand. And then therefore, we get these unexpected or uninterpretable behaviors like the kind we saw in the last slide. So there's a great paper called Concrete Problems in AI Safety. It's written by people from Google and OpenAI, and they talk about some topics that kind of generalize across all kinds of AI. And I won't get into too much detail, but they talk about, you know, avoiding negative side effects, avoiding situations where the neural network can just maximize its reward and then get these unintended consequences, like I mentioned. They talk about making sure we can have oversight over these neural networks. What happens if we train in one distribution or location and then test it in another? What happens then? I'm going to briefly talk about some of the solutions that this paper suggests. So one way to avoid negative side effects is to explicitly limit the impact that a system can have on the world. So, you know, make sure that the outputs of these AI systems or machine learning systems don't actually have much of an influence in the real world. But how can you actually represent change? This is something that hasn't really been formalized yet. Maybe limit the scope of resources available. Don't give difficult problems to the machine learning. Don't give it life and death solutions to solve, and so on. And then they ask a lot of questions in this paper. Do we penalize the AI if it takes an action, or if it takes a wrong action, or merely if it can take any of these actions? So reward hacking is basically this idea of you know, we say to the neural network, here's a bunch of data, be as accurate as possible in differentiating the categories in these data. But there are, if that's all we do and we don't control for any problems, the AI can find shortcuts, and these shortcuts lead to unintended consequences. There's something called Goodhart's law, which I'd recommend looking up. And basically what it says is when a metric is used as a target, it ceases to be a good metric, right? So if you're trying to use something to measure success, then you shouldn't use that as like the input to your system. Basically, you have to be very careful. What is the input to your system? What are you actually trying to classify as output? And third, how do you measure success in the system? And each of those three things really need to be separate from one another. Sometimes people, they just throw all of the available variables in a big bucket, they stir it, and they try to train something that's accurate. But this can, again, result in unintended consequences. So for example, if you're trying to produce a system that can prescribe medicine in a healthcare setting, you might see in a lot of data that in a lot of the data, when there's cases of increased prescription, the patient admissions will decrease. And there's a very strong correlation. Maybe your metric is simply to maximize the correlation between these two variables. And therefore, the kind of logic you might end up with is that I'm just going to maximize prescriptions, even ones that might not be useful, because I want to try to minimize admissions, whereas really that's not the true logic we're meaning to find. I'm going to jump ahead a little bit, but I wanted to mention this part at the bottom. So a big challenge in AI is what to do with the system once it's been trained once. So typically in academia and research, there's a bit of data and we end up spending a lot of time trying to fine tune a model. And then finally, when it's ready, we present it to the world. We discuss our high accuracies and we're very proud of ourselves. But in reality, a model trained in Toronto might not work in, say, a rural community. Even a model trained in Toronto will need to be changed over time. So there's a lot of healthcare changes happening around the world currently with regards to the kind of diseases that are more prevalent, the kind of actions people are being prescribed to take. So we need to take that model that was trained, say, in 2018 in Toronto and adapt it so that it works in a rural community in 2021. So just, I was told that I should give you some practical advice for things you can do in your own organizations. There's a package of code, it's free. It's a collaboration between Google, Microsoft, Amazon, IBM, and others, and it's called Kubeflow. And it's a way that we can combine training models to testing models and validating them to actually deploying them, and then crucially monitoring them. And within this Kubeflow framework, there is something called canary deployment, which allows kind of two models to be run side by side. We have the initial model, and then we gather some new data while that model is running, and we use that data to train a second model. But that second model can fall into traps. It can forget all the useful information that the first model learned. It might overfit and only recognize specifics in this new set of data, which are both problems. The idea in canary deployment is that we'll actually deploy both of these models at the same time. And we'll selectively, when a new piece of data comes in, decide whether to give it to the good old-fashioned tried and tested model or give it to the new, more experimental model. And then we'll see how these models differ from one another, and then we'll compare them. And then given that comparison, we'll make new updates or new decisions as to whether we should route people to the first or the second models. This is actually what Google does behind the scenes when you type in queries or when it's offering you suggestions. There's actually multiple models running, and the AI is trained to kind of recognize what it gets right, what it gets wrong, and it kind of explores the space in a safe way. So we're still deploying experimental models, but in a controlled, safe manner. And then we're doing this thing called canary deployment to allow us to continuously update and monitor our models, adapt to new information as it comes in, but not in a way that completely forgets what we learned previously and in a way that's safe. So I wanted to hammer that home as a practical recommendation for the audience. Now finally, we want our models to be explainable. We want to be able to remove bias, promote safety. We want to be able to leverage domain expertise, maybe discover new knowledge. We want to make sure that a model can generalize and be consistent if applied to new settings, and we want to be able to audit and trust a system. And more than that, we need to be able to understand AI by law. So there's regulatory approval processes happening in the United States and Canada around approving AI for medical devices. And there's also some idea of the right to explanation in Europe through the GDPR, which I want to touch on in a moment. So basically what I want to talk about now is the idea that there's a lot of ways we can promote safety in AI, but I think a crucial one is explainability, ensuring that decisions are explainable. Now I want to mention that this also is a very new sub-area of artificial intelligence. It's only a few years old. even the terminology is not settled yet. So there's this paper that actually shows empirically that sometimes people refer to this field of science as explainable AI, sometimes it's interpretable AI. So even the terminology in this subdomain is changing. So it's you have to keep that in mind. And more than that, if there's n different papers on how to do explainable AI, there's n different models or methods to do it, right? So it's like the Wild West currently in explainable AI. So if a popular method is here, the details don't matter so much, but the core idea is that a neural network might have a very complicated decision boundary, shown here in the difference between the pink region and the blue region. And what this first method called LIME does to explain a decision, say why is this red plus a red plus and not a blue circle, is it will just zoom in on the area around this plus. It will try to find a linear like boundary, this line, between the two categories, ignore all the complicated nonlinearities that we find difficult to understand, and then it'll just pick out a couple of examples on either side of this linear boundary. I think this is a red plus because all the examples on this side of the linear straight line boundary are all red pluses, and everything on the other side are all blue circles. And this is why the model made its decision. I think a bit more interesting for me anyway, you can ignore the math for now, but the key idea here is that we train a neural network to recognize images from the pixels in those images. We can train a second neural network to watch the first and learn what parts inside this neural network are relevant to the decision. So I make a decision that this is a cat. What are the artificial neurons right before that decision that are most relevant to that decision? And then I push that relevance all the way back through the network until I figure out what are the most relevant pixels in the image to make my decision. And what we end up as are heat maps. So here images on the left, and in the middle here are a bunch of different ways we can perform this task. And what we basically see is, well, I think this is a hammerhead shark because of these specific pixels here. And this is another way of explaining decisions visually through these sort of heat maps. And again, we can say, oh, of course, this makes sense because a hammerhead shark has a fin and a head of a certain shape. So that's kind of just to emphasize that there's many different ways we can do explainable AI, but do we have to? And I think the answer is yes. So in the past few years, the FDA in the United States has actually started to approve medical devices, class 1 or class 2 medical devices that use AI. They've started to approve these for mass market consumption, which wasn't the case in 2018. So one of these class 2 medical devices is the Apple Watch, which has the an app that can measure ECG in it. So here's the letter that the FDA's lawyers wrote to Apple, kind of saying that they approve of the Apple Watch as a class 2 medical device. And on the second page, there's a lot of text, which I actually find really reassuring. But one of the pieces of text I want to highlight is that if you want to keep on selling this Apple Watch as a medical device, the user has to be able to correctly interpret the device output and understand when to seek medical care, which I mean is kind of, as lawyers speak, it's very high level, but it kind of touches on the idea that we need to be able to explain the decisions of the Apple Watch when it's making a decision about seeking medical care or not. So explainable AI is starting to seep into the regulatory process in the United States. In Europe, there's also a lot of text around GDPR. Some of that extends back to the 1995 Data Protection Directive, in which we talk about the right to an explanation. And there's a quote along these lines that suggests that the data subject, i.e. the patient, must have the right to obtain an explanation of the decision, no matter what. So this is a recital, so it's not necessarily legally binding, but it shows that the legislators in Europe behind this Data Protection Directive and the GDPR have the notion that the decisions made by machine learning have to be interpretable in some way. So explainable AI is coming, whether we like it or not. Despite all the various ways we might try to proceed, it's coming. We actually have a paper on this topic in JAMA Surgery talking about explainable AI in the operating room. I hope I have a bit more time, maybe 5 more minutes. Okay, thanks so much. I'll just touch on a few more topics on actually what we're doing to deploy AI in the surgical context. I should have warned you about this image beforehand. This is an internal view of a patient. You can imagine this is just a chicken, if you prefer. So I'm part of a company called Surgical Safety Technologies, and we have a product called the OR Black Box, which is a series of technologies that is meant to promote, among efficiencies, team dynamics, general kinds of optimization in and around the operating room. But primarily, we're interested in promoting safety, reducing errors, and obtaining better outcomes, even saving lives. So the OR Black Box kind of brings together a lot of different technologies. We have video cameras placed around the operating room, like you can see here on top. We have cameras inside the body, like you can see in the lower right. We also have patient physiology coming directly from the patient, heart rate, and so on. And we do some analysis. This is a combination of machine learning and human clinical analysis, in which we look for things like we assess for the usefulness of certain kinds of technologies, how well the team, how efficient the team is, how with microphones we can listen to how the team dynamics work, are the teams communicating effectively. But mostly we're interested in looking at technical skill or problems of breaches in protocol. So, I mentioned that part of this involves cameras in the room. So the cameras around the room can watch an operation. This is not an operating room, but the same principle applies. And you can see the outputs of AI. I can automatically detect people in the scene. And it can construct these three-dimensional representations of the OR. So we can see, in a COVID clinic or an ICU, did somebody interact with a patient, touch them, and then touch a piece of equipment without taking off their glove, for example? Or, is there a placement of equipment in the room that is inefficient, making people constantly move around, creating distractions, and so on. So we're very interested in watching the scene from this point of view, using AI and human analysis. The problem is, of course, that this exposes risks of privacy. There's the patient should have their data to be private, but also the doctors. There was a lot of discussion initially, like what is the risk to the doctors if we can identify what they're doing and record them. If there's even a slight mistake being made, do the doctors expose themselves to any kind of liability? We have a paper in the University of Toronto Medical Journal where we talk about privacy versus artificial intelligence in medicine as if they're conflicting forces. And in some ways, they can be conceived of as that. In this paper, we talk about this little quote, how the same month that the GDPR came into effect, Canada issued a new guidance for our own use of personal information in electronic medical records called PIPEDA. And in it, we talk about how an organization has to use data in a way that a reasonable person would consider are appropriate under the circumstances. And I think the main thing here is that, well, what does a reasonable person actually think is appropriate in the age of AI, where we can introduce these technologies that weren't available at all even a few years ago? Like, I mentioned at the very beginning, my very first slide was talking about how we humans have a lot of difficulty in kind of conceiving of our even our healthcare, let alone how our healthcare data is being managed. So, it's a huge challenge that's ahead of us, but I think we can get ahead of it a little bit. So here's an example I'm going to show you of our AI being applied in the operating room. The video is actually from a simulation center, so it's not a real surgery, but there are real surgeons in the scene. So hopefully this video will just play and nothing ill will come of it. Great. So here's like real footage of a simulation center. The first thing the AI does, this is the real output, is it recognizes a contour around all these people. It's 100% confident that that's a person, that's a person. There's a 97% confidence that that's a person. It can apply a mask, removing tattoos, colors, shoes, and completely blur out heads in a scene. And effectively, whenever we record data on site, we pass it through AI. And this is the first algorithm that we do. So we try to remove all the information we can, not only of the patient, but also of the operating team. It's a bit more complicated than this, and maybe we'll get to this in questions, but we're treating it as a very important factor. Privacy of everybody in the operating room is crucial, even when the data is being used mostly by AI. Now, I talked for a lot at a very high level about a lot of topics, and I really wanted to spend more time on kind of core ethics of artificial intelligence in surgery, and maybe talk a bit more philosophically about some of these issues that unfortunately I don't have time to talk about, but I can direct you to this paper. This is going to be a chapter in a textbook coming out this year, hopefully in the next month or two. But we can host it for free on this website. So if you want to visit it, we talk a little bit about kind of traditional medical ethics around surgery, which itself is very interesting. I mean, like there's a lot of like medical ethics theory that is different in the surgical context than in other contexts. And then we kind of contrast it against some of the challenges in AI ethics that we kind of touched upon with regards to safety earlier in this talk. So just to summarize, AI and machine learning are currently being put into a point where they can be actually deployed into practice. And we're seeing more and more medical devices that include AI being deployed. I mentioned very briefly, our own use of AI in practice. And generally, because of some of the challenges we talked about at the very beginning of this talk, there's a strong pull in healthcare for automation generally to avoid some of these problems that we've been seeing, not only in terms of how decisions are made, but also because of inefficiencies and maybe to cut some of the costs in healthcare. AI and other kinds of automation can come to the rescue. But I think we should remember that as our tools are designed to improve safety in healthcare, like the OR black box, those tools themselves have to be made sure that they're safe. So we can't just deploy neural networks, we have to ensure that they're as safe as possible. I want to leave you with this quote, which I love. This is Marshall McLuhan, who I think in the 1960s was talking about mass media, but it applies to AI here. It's first we shape our tools, and thereafter our tools shape us. So still, AI is still very much in the research phase. We're still working out how to produce these tools, but more and more these tools are going to be shaping how we live our lives generally. Thank you so much for taking the time to listen.